practice is to talk about orotracheal intubation. First and foremost, I would like to introduce myself. This is Celeste Carrasquer. I'm an MD, a lung specialist in fact, and currently a teacher at health department in La Costera Educational Center. Costera, located in the town of Xàtiva, Valencia, Spain, is usually considered one of the main professional training centers in our community. Here you will find a wide range of courses, not only those linked to the health department, but also many more. Besides a variety of compelling material resources and also a team of highly skilled teachers are available in our center to help our students. Moreover, and from a personal point of view, if you really enjoy teaching, this is an outstanding place to do it. Currently, I'm teaching students who want to become paramedics, and for them, an overwhelming goal to achieve is to learn about the so-called advanced life support. Advanced life support includes a group of techniques and procedures that are usually performed in, for instance, patients with cardiac or respiratory arrest, and is also part of the care of seriously ill or injured patients. Orotracheal intubation is considered a cornerstone among these procedures and is indicated in every situation in which a definitive control of the airway is needed. Generally speaking, the main role of paramedics in this procedure is to help the medical staff along the orotracheal intubation. Nevertheless, to fulfill this task properly, the students need to take into account several key points. First, they need to learn how to distinguish between the different devices that are commonly used in orotracheal intubation. Secondly, they need to learn how to check the equipment before it is going to be used by the operator. And finally, they need to have a general overview of this procedure in order to help the operator. The first step is to gather the required equipment, which is the following: gloves, protective face shield, or at least a facial mask, a working suction system, a laryngoscope with appropriate blade. There are two main sorts of blades, curved and straight. In this case, we are going to use curved blade. Endotracheal tube with a stylet. There are several sizes of endotracheal tubes according to their internal diameter, but 7, 7.5 and 8 are usually appropriate for most of adult patients. A 10cc syringe, a back valve mask attached to oxygen, tape or endotracheal tube holder, stethoscope, After gathering the equipment, the following step is to check it. Before attempting to intubate, before proceeding, make sure that all the equipment is ready and functioning. This task can be performed by a trained paramedic and includes the following: to place the blade on the laryngoscope handle and check the light. To inflate the endotracheal balloon, searching for leaks. make sure that the suction system is accessible and functioning. In addition, the student should have a general overview of the procedure used in orotracheal intubation, because this will enable them to help the operator properly. This procedure includes the following key points. Standing behind the patient, place the patient's head into the sniffing position by placing a pillow or a folded towel under the patient's neck. This position will increase the alignment of the axis of the oral cavity, pharynx and larynx, that will enhance the visualization of the vocal cords. In a real patient, we should pre-oxygenate the patient with a bag valve mask attached to oxygen for at least 3 minutes. An assistant should perform Celeste maneuver by applying a firm pressure on the cranial cartilage to prevent the regurgitation of gastric content to the airway. Hold the laryngoscope with your left hand, blade down. Open the patient's mouth with your right hand and gently insert the laryngoscope blade into the right side of the patient's mouth and gradually move the tongue to the left to expose the epiglottis. Advance the laryngoscope blade to visualize the epiglottis. Put the tip of the laryngoscope blade into the vallecula. When the tip of the blade is correctly positioned, lift the laryngoscope blade upwards and forwards to visualize the vocal cords. Advance the laryngoscope blade until the epiglottis is visualized or displayed. Put the tip of the blade into the vallecula, and when the tip of the blade is correctly positioned, lift the laryngoscope upwards and forwards at a 45-degree angle, directing the force of your lift along the axis of the laryngoscope handle. Avoid bending your wrist or rocking the blade against the patient's teeth, which can cause damage on these patients or soft oral tissues. Hold the endotracheal tube in your right hand while maintaining the view of the vocal cords. Then pass the endotracheal tube through the vocal cords until it disappears into the trachea. And advance the tube until the balloon is 3 to 4 centimeters beyond the vocal cords. Remove the stylet and advance the tube until the balloon is 3 to 4 centimeters beyond the vocal cords. Remove the laryngoscope and inflate the endotracheal tube with air to prevent air leaking during the ventilation with the bag valve mask. The following step is to confirm the position of the endotracheal tube. The position of the endotracheal tube should be assessed by auscultation. The end of the endotracheal tube should lie in the mid-trachea 3 to 7 centimeters above the carina. A good rule could be 22 centimeters at the teeth for the average size adult. We should assess for an esophageal endotracheal tube placement by auscultating over the stomach during the ventilation. Auscultate both sides of the chest in the mid-axillary line to assess for equal bilateral air movement. If breath sounds are diminished or absent on the left side, it is suggestive of right mainstay intubation. So, we will need to deflate the balloon and gradually withdraw the endotracheal tube until symmetrically sounds are auscultated. The last step is to secure the endotracheal tube to the patient's head once proper position has been confirmed using tape, or if available, an endotracheal tube holder. Using tape, attach the tape to the patient's cheek and wrap it circumferentially around the endotracheal tube, and next fix the free end of the tape to the patient's other cheek. Finally, I would like to highlight some important complications linked to orotracheal intubation that must be taken into account. The most important complication is unrecognized esophageal intubation that can lead to hypoxemia, hypercapnia, and even death. Another important complication is vomiting and aspiration of the gastric content that can cause pneumonitis. Finally, trauma to teeth, lips, and vocal cords can occur also during orotracheal intubation. So, this is the end of this video. Thank you so much to everybody for your attention, especially to my second-year students and to the Costera Professional Training Center. Bye!